Francisco, Scott, David, and I would like to welcome you to the 10th Pediatric Upper Limb and Microsurgery Pulm Talks. Chaired by David McComb, this session will feature Max Horwitz, Jim Higgins, and me as moderators, with Carley Vullermin speaking on single bone forearm fixation.
Carley's orthopedic hand surgeon from Boston Children's Hospital. She originally hails from our part of the world, so there's a connection certainly, and she's presenting the Boston experience with single bone forearm.
Thank you, Dr. McComb, for the invitation to speak today. For the next 10 minutes, I'll present on my preferred technique of performing a single bone forearm formation in pediatric patients. Single bone forearm formation fits clearly into the category of a salvage procedure. That is a procedure performed when no other option exists or other procedures have been unsuccessful or felt to be unsuccessful. It does successfully restore the longitudinal stability of the forearm and provides functional alignment. It commonly resolves pain, however, this is, of course, at the expense of motion. There are several described methods to create a cross-union between the proximal ulnar and the distal radius. The first two are examples from Boston Children's, and the third is from Dan and Scott's series at the Philae Shrine. Whether to resect the proximal radius and distal ulnar depends on the pathology and method used. The first method relies on bone graft from the resected segments, whereas the Philae method relies more on creating a situation akin to a diaphyseal forearm fracture with an end-to-end osteosynthesis. Patient selection is really key. I've already discussed that this is often the end of multiple procedures for a patient. Patients with poor forearm rotation make the best candidates as they have the most to gain without losing so much function. However, patients with pain at the radiocarpal and distal radial ulnar joints also tend to do well. Beware, however, of the less common patient that has ulnohumeral source of their pain. Patients presenting with longitudinal instability can also derive significant benefit. However, they have reduced motion. They may well not be happy with the outcome. I tend to utilize an extensile exposure through the cochlear interval proximally for radial head resection and along the subcutaneous border of the ulna distally in the FCU-ECU interval. I start with radial head resection, and just like in any pediatric radial head resection, it's critical to stay extra periosteal, otherwise the radial head loves to grow back. The posterior interosseous nerve needs to be protected with retractors around the radial neck, and where possible, resection should be just proximal to the biceps insertion, otherwise the biceps will need to be transferred to the ulna. Distally, the ulnar resection will start where the shaft tends to straighten. However, you need to make sure that you've left enough ulna for the side-to-side osteosynthesis. Once the resections have been performed, the section is then taken into the subperiosteal plane along the ulnar shaft. Once you're around the ulnar shaft, you traverse across the interosseous membrane, protecting the AIN and PIN as well as the neurovascular bundles. You need to have a sweeping motion to sort of get through the tissues, and I use a combination of the freer elevator as well as tenotomy scissors. Once you reach the radius, you actually need to extend the window proximally and distally until the radius and ulna can be brought together, as in the top fluoroscopy picture. The fusion bed is then prepared, and you need to lightly decorticate the radius and the ulnar, and you also need to prepare the intercalary graft, removing all soft tissue from it. This next step is probably the hardest and also the most critical point of the procedure. You need to draw the forearm out to length, and then you need to position the forearm between neutral and 20 degrees of pronation. And at the same time, position the graft, make sure the wrist is well aligned, and that there's sufficient bone overlap for the fusion. Finally, placing a KY to hold this and checking all of your positions again, including making sure that the radial head is decompressed sufficiently at the elbow. Only once the K-wire is in place should you put a clamp across the bony construct. Otherwise, otherwise, if you clamp before the KY is in place, you'll actually alter your forearm rotation. Once everything is correct, then you're going to drill proximally and distally. Most commonly, it's a 3.5 millimeter screw, so a 2.5 drill, although you need to match the screw sizes to the patient, and it's not uncommon to need to use a 2.7 or a 2.4 screw. So what has been our experience with this? Recently, Kemble Wang was a fellow with us. He's from Melbourne, and he did the lion's share of the chart review for this paper, which was published in the Journal of Hand Surgery. We found that over a nearly 20-year period, 27 patients with 28 forearms underwent a single bone forearm procedure. This compares to about 20 times as many forearm osteotomies. There was a wide variety of patient ages, and in actual fact, our follow-up was about 7 years, so really quite good. The main pathology was multiple hereditary exostosis, but there were also a number of other pathologies, including brachial plexus birth palsy, congenital radial head dislocation, and ulnius disease. This actually compares to the Philly group, where their patient population, brachial plexus birth injury, predominated. When we look at how long union took, it took on average about 3 months. And you can see here from my example, the 6-week x-ray doesn't show complete union, whereas the 3-month x-ray does. We did achieve a resting position of 10 degrees of pronation, and there's no change in the elbow flexion extension arc. There was a single recurrent occurrence of compartment syndrome, and several patients had ongoing pain. So we looked at pain further. 23 patients had pain as their predominant symptom indicating for the surgery in the first place. 5 had ongoing pain after surgery. And when we looked back, we actually found that 3 of the 5 had degenerative ulnar humeral changes preoperatively. And we thought, well, maybe we can drive into this further and find out whether age had a factor. So then we looked at age, and in actual fact, the news isn't good. We found that if you were younger, under 12 years of age, none of those patients had pain yet. All of the symptomatic ulnar humeral joint patients were older, and all of the non-unions came from that same group of older patients. In retrospect, 2 out of 3 of the non-unions actually occurred in individuals who were smokers. So in conclusion, I think that single bone forearm really does remain a reliable salvage procedure in the forearm of pediatric patients. There are a number of technical pearls because it is a challenging operation, and it is really important to ensure that you've resected enough radius so that you don't get abutment postoperatively. By routine prophylactic fasciotomies, you already have the forearm widely open, and it certainly helps you to sleep better the night after surgery. And I do think that we might need to caution and counsel our older patients a little differently, especially those with pre-existing ulnar humeral degenerative changes. Thank you.
Thanks, Carley. It's great. Dan?
Yeah, thank you, Carley. So it's funny. We have been trying to publish our series of exactly 28 one bone forearms in the Journal of Hand Surgery. So kudos to you for doing what we could not do. I don't know why they don't want to accept it. So I want to talk to you about, I think we should talk about the differences of our techniques. And I think it's really valuable to see where each one fits in, people who aren't doing it, sort of what they should take on and how they should go about it. So let me just say briefly, well, you've seen our technique, you reference it. So we do a sort of an end-to-end. We don't resect the radial head on a routine basis. Actually, we consider that an advantage of the way that we do the one bone forearm. We've had no non-unions so far, but I'm sure that's coming. And we've had that I can think of, I don't think any of our patients have had any elbow problems that they didn't have before, similar to your cases. My concern about, so I have two concerns about your technique, and you can sort of tell me the rationale and the benefit of that versus sort of an end-to-end technique. One is if you take out the radial head, that's equivalent to radial head resection in a child. which we just, I mean, we sort of religiously consider that like a terrible thing to do. And maybe we're overthinking this, right? So let's start there. So your rationale for resecting the radial head on a routine basis and why that's a good idea and should not be of concern.
So I don't think that we routinely resect the radial head, but I think in our patient population, we almost always resect the radial head. And I think the reason is if I look at your series versus our series is almost all MHE, and your series is predominantly brachial plexus. And I think that the pathology in MHE is often abutment at the elbow, which is causing them the pain. And so, and often in MHE, the radius is really shortened. And so even if you did all of that mobilization, you wouldn't decompress the elbow by leaving the radial head there. So that's why I think our tendency has been to take out the radial head. As I was putting together,
but it's all in your case. Sorry, in your case, it's almost always out anyways.
Right.
Yeah. So it's a relative non-issue.
But a lot of those patients can't get out straight because they'll impinge on their radial head. No.
What I mean is taking it out's a relative non-issue. Having it there is the problem. So that's part of the solution. Right. Yeah. So what I'm highlighting, what I'm saying is the details of the patient population. When you look at two studies or two different techniques that are done, but they're done in a different patient populations, I think that's a really good point.
Yeah. And like that was very clear to me. I actually don't have much of a long-term brachial plexus population just because of how old my practice is and also my areas of interest. And I do think that if you look at an MHE forearm, the radius has too much curvature. And if you then put that on the end of the ulnar, you would actually have to create like a McDonald's M in order to get an osteosynthesis that made a straight forearm. And actual fact, putting a plate on that would be much harder. Whereas when you have two bones that are curving around each other and you're bringing them convergently and putting graft in between them, for that group of patients, I think that the morphology lends itself to the side-by-side union.
Yeah, I think, for those who are sort of coming into this brand new, that's a huge difference. The patient population and the actual anatomy that you're dealing with lends itself to a different technique than you would for a plexus, for example, I think. And that's an excellent point. And I think that's really important for people to understand if you're going to be taking on this technique.
Yeah, because I think in the plexus patients, Dan, you're mainly doing it to like solve a 90-degree supination or 110-degree supination contracture. And you sort of know if you cut one bone, you're going to get 30 degrees. If you cut two bones, you can probably go about 60 before the two bones are not in the same address. And so you're actually using it to get you 90 degrees and actually finding that your radius and ulnar, translating them to each other because you're doing like such a big rotation that to me, it makes sense why you would do an end-to-end in that scenario.
Yeah, Carley, have you had, so our experience with radial rotational osteotomies, ulnar rotational osteotomies, has actually been one of very frequent recurrence. And also, I find that when you rotate the bones, you don't preserve the motion that you had pre-op. So it's not like if you had a 75-degree arc of motion ahead of time and you do a 45-degree rotational osteotomy of the radius or 30-degree rotational osteotomy of the radius, it actually eats up your rotational range. So it's not that you're reorienting the arc of motion, you're just positioning it in a place where now you've lost some motion as well. I mean, I don't know if you've had that experience also.
So in patients who have like a decent preserved arc of motion, I found that more in the post-trauma patient, whereas most of the patients who have got stuck in a particular position don't really have, they kind of got a locked forearm already. Mm-hmm. And so in the post-traumatic situation, because there was a normal anatomy to start with and the neuromuscular control is usually normal, I actually have taken to using 3D planning on those forearm osteotomies and found that I am keeping more of the rotation rather than doing more geographic operations. But I think that we've shown that in MHE, doing Materialise or any other computer 3D planning really doesn't offer that advantage that it does in the post-traumatic situation.
Yeah, I think that's a really good point, because when you're dealing with a post-traumatic situation, at one time they were normal, right? And so what you're doing is you're using Materialise to get back to a normal situation for a pretty normal child, right? Or a typical child, whatever the terminology is now. But if you're dealing with MHE, that bone is a very different shape. You're dealing with plexus, the bone is the same, right? It may be hypersupinated, it may be pronated, but it's the same. So yeah, I think that's a really good point. Materialise or any kind of 3D modeling system has been a godsend for I think a lot of the post-traumatic malunions, rotational malunions, angular malunions. And I will tell you that, I don't know if you've had this experience, but it has been the cuts that Materialise tells us to make are completely different than I would have made intraoperatively. And I'm shocked always at how well that works. And what's really interesting also is oftentimes the distal radial ulnar joint, without any reconstruction, even if it's unstable pre-op, will stabilize, which is crazy. Yeah.
And I have not looked at this intellectually, I've just looked at this anecdotally, but I think that some of the forearms that I've done that have been like a long time out from their trauma have actually increased their total arc of motion by using the Materialise,
yeah,
or 3D planning, which I think is good justification for being able to use it.
Yeah, I think that's true. There's a comment from Max that, that if you're going to do any 3D modeling, that to do it on a timely basis. In the U.S., the FDA, right? You know about this? Yeah, well, you can tell them about it.
So Max, in the US, this is very few of the things that we do in pediatric orthopedics actually have FDA approval, and I think that's a good thing. The Materialise has FDA approval, which in Australia would be the TGA, which is just the regulatory body, and we have 3 weeks in like young adolescent, and up to 5 or 6 weeks in anyone up to 19. So so the company is geared for, like, you basically give your operating date and then you give your CT date and you have the CT couriered, and you have to already put aside your time to plan the case with the engineer, because of, in the US, we don't get a choice.
Yeah, I actually have had the Materialise, the 3D prints, the guide blocks stuck in customs. So the US government held them up in customs for too many weeks so that we got them late. And then again, the same government wouldn't allow us to use them because they were too late, which was fantastic. So we had to redo, yeah, true story. So there's a comment here about radiocarpal rotation, Carley. Do you think it makes a difference if you do this at a younger age to get radiocarpal rotation, or more radiocarpal rotation? Meaning, do they compensate more at a younger age? Do they compensate less at a younger age? What level of compensation can you expect?
Yeah, that's a great question. I think that when you have a developmental restriction, deformity, you behave more like a radial synostosis patient. And we know that those patients develop radiocarpal arc of pronation, supination. And I think that I know that a lot of our MHE patients do exactly the same thing. I don't think it's the age that you do the single bone forearm at. I think it's the age at which you lose your ability to have forearm axis rotation. Mm-hmm. And so if you lose your forearm axis rotation at 13 or 14, which is not very common, then I don't think you're going to develop that. But most of the kids actually do develop, similar to the radial synostosis patients, radiocarpal rotation.
Yeah. Oh, another question for me is, I totally agree, by the way. Another question is, we've been doing one bone forearms now for arthrogryposis. Do you have any experience doing that, or thought about that, or have a comment on how stupid an idea that is for me to do?
Arthrogryposis, because they're...
So oftentimes they have the sort of like cobra attack position, right? And that's a terrible position to try to feed yourself, because your forearm is pointing away from it. And I find that if you rotate the humerus, that gets them kind of in the ballpark. But then sometimes they have a very profound pronation deformity, which is actually, it's not, the forearm is not as pronated as the wrist ulnar deviation and flexion. So that FCU tightness that makes them even more ulnarly deviated appearing, right? And takes it away. But I find that if I rotate their forearm, they can suddenly feed themselves. So I have done one bone forearms in arthrographic posts. I'm wondering if that's something that, well, yeah, your thoughts.
Yeah, so I haven't. I do come from the Ozaki school of humeral osteotomy and carpal wedge.
Right.
But if somebody didn't have elbow range of motion and you don't want to take that wrist potentially out of their feeding or personal hygiene space, I can't see a reason to not do it, but I haven't actually done it. I haven't been in practice as long, so I haven't yet.
I wonder if anyone else in the call has any experience with one bone forearms, and so generally, what conditions do you think this is particularly helpful in, and where would you suggest your technique versus an end-on technique, sort of a side-to-side versus end-on?
So in my practice, this is MHE, MHE, MHE.
Yeah.
But that's because I have a mixed hand and pediatric orthopedic practice. And I have great colleagues who are primary plexus specialists. And so therefore I don't do much plexus.
Yeah.
Things like ulnius and other bone dysplasias, congenital radial head dislocations, where you can also have like an element of longitudinal deficiency in the forearm. Where it's like, it looks like it's a radial head, but it's actually the whole forearm that has a deficiency. That's where I think it depends on the bony morphology. I think that in plexus, you often end up with thin gracile bones, but you don't necessarily end up with deformed bones like you do in dysplasias. So I think that probably if the plexus patients that I've done haven't needed that much. And so I've just done diaphyseal rotations and plated them.
Mm-hmm.
I think if I had a really supinated plexus, then I would probably do your technique, because I think that the overall architecture of the forearm is more straight. And so putting it end on end, I can tell you I played a lot more forearm fractures than I do try to get side to side union between the radius and ulnar. And it's not easy putting those screws across it. I always do that drilling and K-wiring myself, because you don't get 2 goes at the drill.
Yeah. Well, thank you. I think we have a
Dave Stewart has got a question.
I just said one. Carley, I recently had to do one of these, and your paper was very helpful, so thank you. My case was a ulnar dysplasia, and so it was quite short compared to the other side, and we're doing it because of a dislocated, painful radial head. And spent a bit of time trying to get the length right, wanting to try and make it a little bit longer, but then running into the problem of, everything getting way too tight. So presumably if you have a lot of MHE cases, you have a similar problem. Do you have any tips about how to get the tension on the flexors and extensors right, how to get the length right? You just make it as long as you can, or?
Not making the hand dysfunctional is the most important part of this operation.
Yeah.
So whatever you do, that has to be the number one. I think that MHE kids are different to congenital longitudinal deficiency kids, because their muscles were programmed and their soft tissues were programmed to be the right length. Whereas kids with congenital longitudinal deficiencies usually have congenital differences of their musculature and nerves, etc., as well. And so I think it's much harder in a congenital situation to acutely stretch a forearm. My bias, and this comes from the fact that I do limb recon, is that if I want to get length, I tend to put my 2 ends of my bone together and have a frame on it and then gradually lengthen, rather than try to get, so, in your situation, I might have tried to get as much as I could that was safe. Mm-hmm. And then if the patient needed forearm length,
subsequently distracted.
Maybe think about distracting it later.
Okay.
Proximal to your union site. Yeah. Otherwise, I think that would be difficult to go through that giant bone block.
Oh, no, no. Do it as a metaphyseal lengthening, and metaphyseal lengthenings in the ulna are best done in the proximal ulna, like if you were doing some lengthening for a Monteggia reconstruction or something.
Yeah. All right, great.
Thank
Well, thank you, Carley.
Thanks,
Any other questions from anyone?
I only one last question, I guess. The long term, in the adult population, you see one bone forearm mainly used for trauma and as sort of end of line type of procedure, and the degenerative changes you see from the increased stress across the ulnohumeral joint. I guess we're not in a situation where we've got many choices when we're getting to this sort of procedure, but that becomes even more worrisome when you're dealing with kids, doesn't it?
Yeah, that's why I said that none of the ones under 12 have pain yet, because some of them do have abnormal ulnohumeral joints. We also know that sometimes people who grow up with a certain affliction, as opposed to somebody who develops it later in life, are more tolerant. It's not that brachial plexus patients have great shoulders, it's just that they've never had a different shoulder. And that's why their shoulders are okay. So I think that sometimes our patients are more tolerating. I don't know that they don't experience the pain. And 7 years is still a very short outcome study in pediatrics.
Yeah, and David, I would also say this. I would say this is a working theory at this point of mine, but I think that if a patient, typically the MHE patients are in varus at the elbow.
Yeah.
And so they're not, when they load their forearms, they're loading their forearms in varus, which means that they're loading the medial side of the elbow. If it was going the other way, if their forearms were in valgus, and I don't know if you pay attention to this, Carley, or if this is a thing that you think about when you're doing your one bone forearms, but if you're not going to correct it, they're going to stay in varus, and I think that's protective of the lateral side of the elbow, or I should say protective of that valgus force that you can't resist because you don't have a radial head. So that's my working theory.
Yeah, the long-term follow-up with these kids, as in the 20-year and the 30-year and the 40-year thing, it's fascinating, I think. So anyway, to our last speaker, thanks, Carley, and thanks, Dan.
Make sure to catch our next session on April 11th, featuring Don Bay on lateral condyle fractures, Carolyn Leclerc on hyponeurotization and cerebral palsy, and Wendong Xu on contralateral C7 and cerebral palsy. This will be chaired by me, with Juan Jose, Gil, Wee Lam, and Scott Cozen as moderators. Thank you.